So case 2. This is a 35-year-old woman with a firm papule on the cheek. Mm-hmm. It's no problem. This is all good. Je suis à Paris, so c'est bon. I'm super happy. So this is case 2, a 35-year-old woman with a firm papule on the cheek and a shave biopsy, see? Now this is a good shave biopsy, nice and deep. Sometimes not so much. It will be like this or maybe like this, and then it's more difficult, right? And I like to always, when I'm working with my residents and fellows, but even myself, I think, would I have made the diagnosis if the shave biopsy went to here or here? And even on excisions, I try to think, what would I have called this if I only had a superficial shave? It's a very scary game to play, but it's good to practice thinking about how to approach small biopsies of larger lesions. So here we have 3 pieces of tissue. And from low power, the first thing that I notice is these large keratin-filled milia or microcysts filled with keratin. And the second thing is you can see that there's a little bit of normal dermis out here, but the dermis here is very bright pink, dense, increased sclerotic collagen, and there are small islands, cords, nests, strands, whatever words you like, of something infiltrating, trickling in between this dense collagen. So that's what I see at low power. Let's go closer. The keratin cysts look like any other benign keratin cyst. The epidermoid cyst or milium or dilated hair follicle is all the same. They're lined by multiple layers of benign keratinocytes with a bit of granular layer and loose keratin contents. And like any keratin-based cyst, they have a tendency to rupture sometimes. And when they do, they create a foreign body keratin giant cell reaction or keratin granuloma, very common. Sometimes the granulomas can become calcified. I can't remember, yes, there, right there, see? Calcium is very common to see alongside these ruptured small cysts. Okay, so let's look at the center of the lesion. So we see islands, elongated kind of cords and strands of basaloid cells. And they, again, have a very infiltrative appearance, right? Because they are intercalating or trickling, whatever word you like, between the background collagen. And the collagen behind them is very dense, more dense than normal dermal collagen. The collagen density of the dermis is a subtle clue, but I think it can be helpful in some lesions. So it's worth studying normal skin to see what the texture and density of the normal papillary dermis looks like and the normal reticular dermis, because sometimes subtle changes in that collagen pattern or density or texture can be very important clues for different diagnoses. All right? The cells are very bland. They all look perfectly identical, small, round cells, very bland, no pleomorphism, very little, if any, mitotic activity. The stroma is dense collagen with no blue myxoid color, no clefting or splitting, all right? And some people would say that the shape of these nests kind of look like a tadpole, right? I don't know, comment tu dis en français? Tadpole, the little baby frogs. Tita? Oh, tita, that's so cute. Yes. Très belle. Tita, okay. So tadpole in English. And, or the ties that people wore long ago, paisley. How do you use it? Cravata. Ah, yes. So the paisley tie pattern is what we often say in English. where you have a larger area and then a small tail coming off behind. So there is a differential, a classic differential diagnosis for this pattern in dermatopathology. And the four main entities that we talk about are syringoma, basal cell carcinoma, morphiiform basal cell carcinoma, or I usually just call them infiltrative basal cell carcinoma to encompass morphiiform and micronodular. That's the way I do in my practice, but the other two things are desmoplastic trichoepithelioma and also microcystic adnexal carcinoma, or MAC is the other short name that we use as an acronym in English. Do you use acronyms in pathology in France? Like where you use the first letter from each word? It's very common in English, but I know people in my colleagues in Spanish-speaking countries are like, they don't do that as often, so maybe it is just an American thing. Okay. So the differential of those, I think syringoma is usually the easiest to exclude because syringoma has obvious sweat duct formation. You can usually see easily sweat ducts in each of the islands here, and they are multiple, not just rare. So here, these don't have any ducts that I can see, right? They're solid strands. The only openings or spaces are these. But this is just keratin material. These are not sweat gland secretion in a duct. Sometimes it is difficult to be sure if you're dealing with a duct with some sweat secretion, or if you're dealing with a little cyst with keratin debris. I think it can be challenging in some cases to tell that apart. But I think these are all little tiny keratin cysts with swirls of keratin, similar to this, analogous to that. Okay. So syringoma, I think, is excluded. There's no ducts. Basal cell carcinoma can have infiltrative cords, but usually, if you have a large enough biopsy, you will see obvious areas of classic basal cell carcinoma somewhere on the biopsy. Not always, but most cases will have some areas with larger nests connecting to the epidermis, basal palisading, clefting artifacts, myxoid stroma change. I have seen a small number that did not have those features, but most of the time you can see those findings. So what I think we usually end up being left with is desmoplastic trichoepithelioma versus microcystic adnexal carcinoma. And that is very challenging and difficult to distinguish, I feel, especially on a shave biopsy. The important feature to see is duct formation, to see sweat ducts, because microcystic adnexal carcinoma is a sweat gland or sweat duct neoplasm, and desmoplastic trichoepithelioma is a hair follicle tumor. But the problem is that the ducts in microcystic adnexal carcinoma are often very small and subtle, and often they are best seen deep down in the lesion, at the very deep dermis or even the subcutis. So on a shave biopsy, you often cannot see them well. The other problem that arises is that sometimes, let me see. Sometimes you will find a duct, a sweat duct, but you're not sure, does the sweat duct belong to the tumor, or is it just a background sweat duct that happened to be trapped in the middle? And I think this is true of all of the tumors where we're thinking of sweat gland differentiation or sweat duct. It can be challenging to know if one duct is just entrapped or if it's truly part of the neoplasm. I can't remember if this case had, down. Yes. So you can wonder, are you seeing an entrapped duct or not? So that's another difficulty that I encounter. So you can try some immunostains here. Carcinoembryonic antigen, CEA. I find one of the more useful stains to highlight sweat ducts. The apical lumen lining of the duct will stain strongly, but is not a perfect stain. For one thing, when the ducts are very compressed, it can be challenging to interpret. The clone of CEA that we use in Okay, carcinoembryonic antigen, we'll just stick with that, in our laboratory, it will stain neutrophils a lot of times. I think that must be a clone specific, and I don't remember what clone we use. But the other thing too is that sometimes keratin debris can non-specifically stain with carcinoembryonic antigen. So it's not perfect. I find it most helpful if I'm looking at a tumor that I think is either maybe poroma versus seborrheic keratosis, and I see cystic spaces, or squamous cell carcinoma in situ versus porocarcinoma. I see spaces that look like a duct, and I do carcinoembryonic antigen, and they're totally negative. Well, probably it's just a artifactual space, not a true sweat duct. When I can't see ducts on H&E, I find that carcinoembryonic antigen is not terribly helpful. And you can try epithelial membrane antigen, but it stains a lot of things. I don't find it as useful. One stain that I do like here is cytokeratin 20, CK20. Cytokeratin 20 in desmoplastic trichoepithelioma and in many hair follicle tumors will highlight benign Merkel cells scattered in the midst as kind of colonizing the tumor. And you don't usually see those cells, or very few of them, in microcystic adnexocarcinoma or basal cell carcinoma. So of the stains that I've used over time, that one I personally find the most useful. Even still, on a biopsy like this, I would feel very comfortable saying desmoplastic trichoepithelioma based on the morphology. And if I had cytokeratin 20 cells, that would be great. I think this case was one from a teaching collection, so I don't know if CK20 was performed here or not. But I think this looks very classic to me for desmoplastic trichoepithelioma. But on a very small biopsy, I find that even with the immunostains, in the end, I still add a comment saying, well, I'm not totally sure, and I'd like to see how deep the tumor goes. Desmoplastic trichoepithelioma is usually confined to the dermis and has maybe minimal or no involvement of the subcutis. If you see extensive infiltrative growth deep down, that is very worrisome that you're probably dealing with microcystic adnexal carcinoma or some other type of adnexal carcinoma. Now, one thing I mentioned in the handout, but let me see, I think I have it. But is the idea of perineural involvement, okay? I was trained that if the tumor infiltrates around a nerve, then it is malignant and it is microcystic adnexal carcinoma. But over time, there have been papers published saying that you can actually see nerve involvement in benign desmoplastic trichoepithelioma, and that with follow-up, those patients have a good outcome. When I first heard that, I did not believe. I thought, no, it doesn't make sense. Sometimes science challenges our preconceived ideas. But the paper was published by a very good group, the group at Yale University, Dr. Jennifer McNiff's group, and they published excellent material. And when I actually took the time and read the paper, I thought it was a very convincing argument. And in practice, I've now seen a couple of cases that I call desmoplastic trichoepithelioma that did have small dermal nerve involvement. And to my knowledge, no bad outcome happened from those cases. So it makes you feel uncomfortable to see that, but it made me feel better once I realized that the literature describes this and says actually it's not rare, but a relatively common finding in this tumor. Now, I see dermpath cases, many cases every day, but I only encounter desmoplastic trichoepithelioma maybe, 3 or 4 times a year maximum. So these are rare tumors. So I don't see them very often. And if there's any doubt, I usually do say I would like them to either do two options. They can do a deep punch down to the level of fat or a small ellipse. Because remember, these do often occur on the face in young adults. So there is a cosmetic implication here that you may be leaving an unnecessary excision may leave a large or a noticeable scar on the face of a young adult who otherwise may not have facial blemishes. Maybe that's not as serious as some of the side effects of the treatments that we have for patients, but it's something worth thinking about, I believe. We always have to make sure that we are taking patient well-being and avoiding problems for the patient and that's harmful, but also I think cosmetic results are something we should take into account and think about. All right, so let me see if I have it here. I think I have another example. These are my unposted cases. So you're seeing the secret, I can't spell. Because that's not it. This French keyboard is very challenging for me. So you're seeing the secret unposted cases that I've got. I've got a bunch of them. I think it was. And see, this is a nice excision, right? And you can see the lesion stops right there at the dermal subcutaneous junction. Look at the calcifications. Look at the cysts, cords, dense collagen, all the stuff I just showed you. But you can have small nerve involvement where the tumor sits right next to the nerve. So I don't call that perineural invasion. I just say it's it's perineural growth of the tumor. All right. We use different words depending on if we want something to be cancer or benign, right? It's true. All right. Well, I'll have to take a picture and post it later on Twitter. All right. So any questions here? Very challenging diagnosis. This is what you would see in a benign hair follicle tumor, like a desmoplastic trichoepithelioma. This particular case was, if I recall, a trichofolliculoma, and I just did the stain for educational purposes, and it worked beautifully. So if you do cytokeratin 20 on normal skin, or the next time maybe you're thinking, is this basal cell or Merkel cell carcinoma? And you do keratin 20, look at the epidermis and the hair follicles of the normal skin, and you will often see scattered occasional CK20 positive cells. They often have kind of a slightly branching dendritic appearance, and they're usually located along the basal layer, often within the hair follicle openings or down in the hair follicle. And those are normal benign Merkel cells, okay? I have looked, and I cannot recognize them on H&E. I've even looked in cases like this where I know there are lots, and I look closely, so I don't know what they look like on H&E. I must be seeing them, but I do not recognize them. So, but you can find them on CK20. Also, if you happen to do like a CAM 5.2 or other low molecular weight cytokeratins, sometimes you'll see random cells staining in the epidermis. That's what you're seeing, is these benign Merkel cells. So when you have many of them scattered in the middle of a basaloid neoplasm, that is a very nice supportive feature that points in favor of a benign hair follicle neoplasm, okay? So usually you will not see this in basal cell carcinoma, and you usually will not see these cells in microcystic adnexal. Or you might see one or two, but not many. In a benign hair follicle tumors, they're usually scattered throughout. Now, I have tried this once or twice for trichoepithelioma, and I did not see any. So I don't think this works. Trichoepithelioma, because it's so close to the epidermis, doesn't seem to have the cytokeratin 20. I don't know. Have you tried this on trichoepithelioma? I just tried it for education once or twice, and on things that I was certain were trichoepithelioma, and I didn't see them. So, but many other, like trichoepithelioma, desmoplastic trichoepithelioma, trichoblastomas usually, you will tend to see these scattered Merkel cells. Kind of passengers, they're just on the train for a ride, right? They're not part of the tumor, they're just hanging out with the tumor. So that's the way I think of it. That's a closer look. So those are and whenever I mention these in my microscopic description, I say cytokeratin 20 stains scattered benign Merkel cells. I make sure to include that word because Merkel cell by itself, even though it's a normal cell type, to most doctors, that means bad cancer, right? So just to make sure that there's no confusion, I say they are benign Merkel cells and they're scattered there, colonizing the tumor. This supports a benign hair follicle tumor. So I don't mind being redundant. As you can tell, I am very verbose. I use lots of words when I talk, and I use lots of words when I write. Je suis désolé. It's just the way I am.